Recording in progress.
Okay, you have the floor now. You have 10 minutes.
Okay. Good morning, facilitators. Good morning, teachers. Good morning, colleagues. I'm taking practice question 9. So the question goes thus: a male student developed a pruritic rash after wearing his friend's boxers. A picture of the rash is shown below. Question 1, describe the lesion. Question 2, what's the diagnosis? Then list 3 medications used for treatments and mechanism of actions of the medication. Then what are the health issues to be addressed and how would you educate this patient? Then list 5 complications. So to answer the questions, to describe the lesion, I'll just go back to it so that we can describe it. It's actually there are multiple erythematous papules that are on the shafts of the penis, the glands of the penis, the scrotal sac, as well as the upper thighs, or you can say the adjacent thighs. The diagnosis for this condition is scabies, but I chose to write classic scabies because they gave us a young person and they didn't give any history of immunosuppression, which might suggest the other variant, which is the cross-test scabies. So I chose classic scabies. The 3 medications and mechanism of action that can be used to manage this condition: 5% permethrin, and the mechanism of action is that it impairs both ticketed sodium channels in insects, disrupting neurotransmission, eventually causing neurotoxicity. Ivermectin, which binds to the glutamic-gated channels, increasing permeability of the cell membrane to chloride, does hyperpolarization, paralysis, and death. Eventually, it's still neurotoxicity. Then another drug is benzyl benzoate, which is commonly used in places where other ones are not readily available, which is absorbed by mites, and it's also neurotoxic. What I would like to discuss with the patient are the health issues. Okay, health issues to be addressed and how we educate the patient. I'd like to address, talk with the patient, making them understand that this can actually cause intense pruritus, which can actually be quite extensive and eventually can get infected and cause a lot of other conditions, and it can actually disrupt the quality of life. It may also cause some level of stigma, since scabies generally is associated with dirtiness in the rural environment where they don't really have much of a poor understanding. Then I also need to make them understand that scabies is actually highly transmissible, where sharing underwears, just like he has done, will actually ease transmission, even though we know that the life cycle of the mite is quite short, and usually outside the body, within the 24-hour period, the mite will die. Sharing the underwears can actually play a role, as well as sharing beddings and bed sheets, and then direct skin contact. I will need to address those with the patient as well. Complications that we can have in this condition: superimposed bacterial infection, which can actually cause a form of dermatitis, or impetigo as well. This can be caused by staph or strep. They can also have insomnia, because this itching tends to be more at night, and intense pruritus can disrupt their sleep pattern. They can have glomerulonephritis, where the skin lesions can eventually result in a post-stroke glomerulonephritis. They could also have infective endocarditis. They could get depressed in view of the intense pruritus, the dirty appearance it gives generally, and the fact that they're really not getting much response to what they're doing. Then the scabies can actually result in outbreaks. This scenario that's given to us is a student, so it's probably easy to think that he may actually have been in the dormitory, which may have given access to sharing boxers as well as maybe sharing beddings, and being close together in a closed space as overcrowding. So I'll quickly talk briefly on scabies. I have 5 minutes for that, I believe. It's an ectoparasite infestation caused by the mite Sarcoptes scabies. The one that actually caused one in human Sarcoptes scabies hominis. Outbreaks are known to occur in preschools, hospitals, nursing homes, prisons, and other institutional residences. I will assume that in this case, the person was possibly in a hostel. It can affect all races and all people, all social classes, and common in children and young adults. These are the ones that actually tend to stay in those close places together. They are more common in poorer countries with social overcrowding, especially suburban Africa. And at any time, there are approximately 130 million untreated cases. The fertilized female mites are actually the ones that cause this infection. They're the ones that are transmissible from one person to another by direct skin contact. The gravid female mites, they burrowed superficially within the stratum corneum, despite releasing several eggs. Okay, the 6 egg larvae mature to about 8 leg nymphs, which are the adults. Gravid adult females emerge on the surface of the skin after about 8 days and invade the skin. Generally, the mites die within a day or so in the absence of a suitable host, which means outside the body, it might not really last that long. We have a very short one. Things that can facilitate transfer, therefore, in view of this, will be the overcrowding, poor hygiene, immunosuppression, sharing of contaminated beddings or clothing, prolonged use of physical contact with other persons, including sexual contact. A person's initial infestation remains asymptomatic for about 6 days. That's during the first one. because this actually is a delayed hypersensitivity reaction that they have to the mites, the feces, or the parts of the mites, basically. So after about 6 days, they have the intense pruritus. However, if they've had a prior exposure, meaning there's already sensitization to the presence of the mites, it usually takes shorter, within a day, within a few days, they start manifesting. Widespread, intensely itching, excoriated erythematous rash to the mite antigen. Look, I mentioned that already. Pruritus is worse at night. There's small red papules, vesicles, occasionally pustules occur everywhere. But in our case, we don't really have vesicles and pustules. Maybe if you actually examine properly, you find those. The rash may be complicated by secondary bacterial infections. The features, the areas that you can actually get these lesions are commonly in the flexural areas, and also the elbow. Finger webs, palm, soles, wrists, axillae, male genitalia, around the umbilicus, around the nipples. This is just a picture showing the itchy papules, which you notice are more around the west spaces. Then there's an entity or a variant called crusted scabies or Norwegian scabies, which is a variant and is more common in elderly and immunocompromised people. That's why I specifically talk about classic scabies for these patients. Pruritus may be mild or absent. Our patient actually had pruritus. They are highly infectious and maybe the source of outbreak because they actually don't have the symptoms, so it's easy for them to spread it. And then another thing about crusted scabies is that the mite load is usually in millions, as against the classic scabies where it's just in few tens or hundreds. They usually have hyperkeratotic crusted lesions, characteristic that affect the hands and feet. They may be widespread inflammatory rash and scaly crusted plaques. This is just a picture. You can look at the hyperkeratotic lesions in the web spaces. The diagnostic sign is fine linear or curved burrows, which are seen. The burrows could be sought on roofs using sterile needle. You can also do the adhesive tape test to get these lesions. Then you can view under microscopy. You apply potassium hydroxide to remove the keratin material so you can view it properly, and then you can see the mites or you can see the eggs or the head, depending on where you get it. This is just the presence of burrows of microscopy. Then the mites, this is a picture of the mite still in its egg. Usually the mites have about 6 legs, while the adult ones have about 8 legs. Complications that can occur in impetigo, where they have secondary bacterial infections, cellulitis, invasive bacterial infections, post-radical glomerulonephritis, infective endocarditis. To manage, preferred initial therapy recommended by FDA is with permethrin, which is usually applied from the neck down, and then you leave it overnight, wash it off after about 8 hours, and then usually it's fine, but it can be repeated much later, after about a week or two. You can also use oral ivermectin at 250 micrograms per kg, giving start and can be repeated after 1 week. And you can also give benzoate, which is actually also applied and used overnight for a few days. Alternative therapies include topical sulfur, topical ivermectin, that's about 1%, topical spinoside, topical glutamate, and then topical lindane. Then okay, I think I've mentioned this already. I can just, you can, the pruritus itself can be used, you can manage with antihistamine. There's a role for steroids, but that's usually used only when you've eradicated the mites. It doesn't have a scabicidal effect. Other things that you can use, okay, yes, I think I've talked about all these ones already. So for treatment to be successful and measures listed, these are 3 things. I think I should have added this to the answer given later. They also need to wash their beddings under in hot water at least 60 degrees and above, or you can keep them under sun, knowing fully well that after about a 24-hour period, you might not find any of the mites available anymore. So treat all skin below the neck, including genitalia, palms, soles, and under the nails. Treat the head, neck regions in infants up to 2 years of age. Treat all close contact at the same time if it's asymptomatic. Reapply scabicide to the hands if they were washed during the treatment period. Wash or clean recently worn clothes, preferably at 60 degrees Celsius, to avoid infections. Repeat application after 1 week. So the prognosis, within a day of effective treatment, scabies infections become non-communicable, but the pruritic hypersensitivity dermatitis induced by the dead mites and their detritus frequently persists for weeks. Thus, unnecessary treatment with topical agents may provoke contact dermatitis, especially from repeated applications of permethrin cream. Topical emollients, menthol, methyl salicylate products, and oral antihistamines relieve itching. I also saw somewhere that calamine lotion, but I know that the dermatologists don't feel very comfortable with that, so I didn't add it to the slide. Topical glucocorticoids may calm pruritus and that lingers after the effective treatment. I'll give some acknowledgement to Dr. Egugoze Emmanuel, who actually used his slides for this. Thank you all. That's my response.
Wow, thank you so much, Dr. Justice, for that very lucid and concise presentation. And you so kept to time. I think you still have 1 minute. Thank you so much. Okay, so right now we'll take comments and questions from the participants first. And then let's keep the thanks coming on the chat. Let's keep the thanks coming on the chat. Okay. Okay, so there's a hand. Okay, there are two hands up already. Thank you so much, Dr. Wiki. Please go ahead.
Okay, thank you very much, Dr. Justice, for this beautiful presentation. Good morning, everyone. Good morning, our teachers. Okay, my comment is just about the prevention. Okay, for the treatment also, Dr. Justice, you didn't maybe you didn't remember to mention the treatment of the people, the contacts of these persons that that were in contact with the patient, even if they are not showing any symptoms, it's also very important to treat them. Okay, then another thing I want to find out, why do you think the rashes, the itching is worse at night? Thank you for your presentation.
Thank you very much, ma. Thank you very much. It's actually well noted. I actually didn't. Oh, I actually wrote it down. Sorry, I apologize. I wrote it down. I was supposed to check for it. I didn't do that. I'm sorry about that, please.
So, Dr. Justice, you can see what you're typing.
Yes, I actually didn't check it. So this is me trying to check it now. Yes, I didn't check it.
Okay, you can stop the share.
Because of the body temperature, maybe it's warmer at night and the skin is dry, so that's why they feel that itching more at night.
Okay, thank you very much.
For the washing too, like sanitizing the wears, beddings. There's also a place where you don't have that high temperature to wash and sanitize the beddings. Also, so that you can actually gather the beddings, the wares around the house, tie in plastic bags and keep for some days. And because, like you rightly mentioned, if the mites are not on the body, they can die where they don't see where they burrow and explore. They can die within 2 to 3 days. Okay.
Thank you very much.
Yeah. The scabies sites as well. There is a place too for reapplication after 1 week. I don't know if you come across that and the reason for that application. Maybe I think the eggs, in case if the eggs hatch, they can also be attacked by the scabies sites. Thank you very much.
Thank you very much, Chief.
Oh, thank you so much, Dr. Wiki, for that beautiful addition. Okay, Dr. Florence, you have the floor.
Okay, thank you so much, Dr. Justice. You always do justice to your job. Okay, I really wanted to repeat what the previous speaker talked about, the prevention level. So just to add on to what she said, so knowing he's a young man who may be sexually active, so people he has had, like we have to do like a contact tracing, or people he has had sexual contact with within the last 1 month. So all of these people should get treated for scabies. Then also people living with him should also be treated also for scabies. Then also advice to be given to him because after taking the medications, he may want to know like when can he get back to being active in that aspect. So most times it's advisable to tell the patient to wait about 2 to 4 weeks when we are sure that there's no reoccurrence, then he can now get back to being sexually active. But most times, about like 1 month thereafter, after treatment, he can get back to doing whatever thing he has to do. So that's just the add-on. Then again, as regards to what she said, beddings that have been used in the last 3 days, should be soaked in hot water and washed thoroughly. Thank you very much.
Thank you very much, Chief.
Oh, thank you so much, Dr. Kalama, for that beautiful addition. Okay, Dr. Asekhem.
Good morning, ma.
Dr. Asekame, please, you have the floor.
Good morning, ma. Thank you, Dr. Kelly. Thank you, Dr. Ibiti. Thank you to everyone and the organizers of this forum. I have a few clarifications from the presentation and then a comment. So my clarification is that it's about the dosing and of ivermectin. I don't know if you came across that. because it's something that's actually personally confused me. How long should it be given, and what is actually the appropriate dosing? The second clarification is with regards to calamine lotion and steroids. You mentioned that calamine lotion seems to be falling out of favor. I just want to confirm from the dermatologist also, if I don't know if you're a dermatologist, sorry about that, but if that really phased out. And then for steroids, I'm wondering if steroids will be appropriate when you have an active infectious disease like scabies. You're still using steroids. I just want to clarify that. The comment is on the use of the word insomnia when you were mentioning the complications of scabies. There are many sleep disturbances, insomnias and parasomnias. But if a person is not sleeping because he's itching, I don't think that's insomnia. I think I stand to be corrected. I mean, all those disturbances, there are many symptoms that can make a patient not sleep. Insomnia, pain, neuropathic pain, PMD for the cardiologists, but that will not be called insomnia if something else is making the person not to sleep. But I stand to be corrected. Thank you.
Okay. Thank you very much, Chief. Thank you very much for your questions. I'm not a dermatologist, though. I will start with the ivermectin dose. It's 250 microgram per kg, given as a start dose, and it can be repeated after 1 to 2 weeks. That's for the ivermectin. Then the calamine lotion. Well, I don't have the authority to say it's been phased out. The reason why I mentioned that, I noticed that I had a discussion once with some dermatologists, and when I mentioned calamine lotion, it was hugely frowned at. But eventually what we arrived at from that discussion was that even if we were to say it, we should emphasize the fact that it's not scabicidal. It can give a soothing effect, which is mainly for the pruritus. But then the fact that it gives you the whole white appearance and discoloring is not really comfortable for something that a lot of other options exist for the itching. Then for steroids, I mentioned that we only bring steroids in when you're done with the eradication of the mites themselves. You've given your scabicidal medications already, not really when there is an active infectious process. Bearing in mind also that the moment you give these drugs, they usually become non-infectious within a short period after that. Yes. Then for the insomnia, I honestly cannot give a response to that. I actually mentioned it because of the fact that, just like you said, the pruritus tends to be worse at night and the itching tends to be more disturbing. So that really takes them away from sleep. Sorry, I don't know if there's another one that I have not addressed. These are the ones I wrote down.
Thank you.
I think you've addressed them. Yeah. Thank you so much, Dr. Asekame. Thank you, Dr. Justice. Okay, so we'll take comment from Dr. Adeyemo and then thereafter Dr. Jamila, and then I'll go to the chat. Okay.
Yeah, good morning. Good morning, colleagues. Good morning, facilitators. Good morning, our trainers. Thank you, Dr. Justice, for that beautiful presentation. I just wanted to add to the aspect of the management. It's all very important to counsel the patient that even after treatment, even after complete eradication of the mites, patient can still continue to have pruritus, because some people can still continue to have the immunological basis is delayed type 4 hypersensitivity reaction. So the fact that the mite has been eradicated does not mean that the egg has been completely eradicated. So some people can still continue to have reactions to the egg, even after complete eradication of the mite. So it's very important that we let the patient to be aware, even because patient might still continue to complain of pruritus. And then for the aspect of depression, a lot of them can actually come down with depression. And it's very important to also let them know that they benefit from cognitive behavioral therapy, which is like a form of talking therapy sections. Patient can actually benefit from CBT. Thank you for the presentation.
Thank you very much, Chief.
Thank you so much, Dr. Adeyemo. Okay, so Dr. Jamila, go on, ma.
Good morning, everyone. Thank you, Dr. Justice, for the beautiful presentation. I just want to make a few clarifications. When you started the presentation, you said because they didn't mention any form of immunosuppression, so you just selected classic scabies as the diagnosis. Well, apart from that, when you look at the lesions, they are not typical of the crusted the one seen in immunosuppressive patients. In crusted scabies, you see these hyperkeratotic scaly plaques. So, but when you look at these lesions, they are just erythematous, multiple erythematous papules on the external genitalia. So even from the pictogram, that's from the picture, you know that it's not likely to be crusted scabies. Then okay, pertaining ivermectin, you can use it to treat scabies and also treat those that do not have the scabies. So, and this means that when you're treating scabies, you treat the whole household. You don't treat only some symptomatic patient. So the ivermectin, you can use it in treating those that are symptomatic and those that are not, that are asymptomatic. So for the dose, it is 200 microgram per kg, and it is given on specific dates. So usually you give it when you're treating the scabies. For classic scabies, you give it orally on day 1 and then day 8. But for crusted scabies, you give it on day 1, 2, 8, 9, and 15. Then also pertaining the treatment of scabies, there are drugs that are considered safe in pregnancy, because it's not all the drugs that are safe in pregnancy, because sometimes a pregnant person can be infested with scabies as well. So the drugs that are considered safe in pregnancy include the sulfur ointment and then permethrin. Though permethrin is under category B. Then also in the treatment, you also need to you also need to ask the patient to wash their clothing. I don't know if you mentioned that, sorry. You need to ask them to wash their clothing in hot water and iron them. And also clothes and things that cannot be washed, you seal it in a tight, airtight bag, and then allow it for some days under the sun before you bring it back in. And then you also need to vacuum to clean the house, because in crusted scabies you can even find the mites in the environment. Thank you. I think those are the okay. And then another reason for why the itching is more at night is because at that time it's not like the itching, they don't feel it in the day, but it's because at that time they are calm, they are at a state of rest. So that is why the itching is more noticeable. That is what is as in the first thing that is being mentioned before you can add what the earlier person mentioned. Thank you.
Thank you very much.
Thank you so much. Thank you so much, Dr. Jamila. Okay. So we'll take Dr. Owa. Shoaibu. Hello, Chief. Are you there? Okay.
Yes,
If
good
he's
morning, my
not
teacher.
there,
Good morning.
then okay.
I'm here. Hello?
Okay.
Hello? Can you hear me?
Yeah. I can hear you now. I can hear you.
Yes. Good morning, my teachers. Good morning, the presenter. Dr. Justice, thank you very much for actually doing justice to the question. I raised my hand before Jamila spoke, but I wanted to comment on the dose of ivermectin. It's actually 200 microgram per kg, and you repeat it at the 8. However, it's worth noting that it's not given in children, because you made mention of brightly treating the house contacts. So it's not given for children, please, that are less than 15 days, even among pregnant and lactating mothers. Rather, you give them a different thing. You can give them benzyl benzoate. However, mostly it comes in a dose of 20% in a strength, sorry. or 20%. So it's important because this is a practical thing and it's very cheap, it's commonly available. So when we are treating scabies, we might likely get the UV lotion, which can also be used even alone without giving actually the ivermectin. Ivermectin is still cheap, but it's not easily available, especially in the cities. So when we are using the DB lotion, please, in children, we need to dilute it with equal amount of water. So, for example, if you are using a cup of the bottle, maybe you use 2 cups of bottle and you are giving it to children. You have to use equal amount of water to dilute it. And if it's an infant that you are going to use, you have to dilute it by 4, meaning that if it's 25%, you dilute it to 12.5% for children, and then for infants, you have to dilute it to 6% also. Yes, and it's important just to note that looking at the picture, there is some affectation of the genitals in this patient, even the glands penis. So where he has classical nodular scabies. So it's important for us to know because the patient can come with nodular scabies, involvement of the finish. Such scabies usually tends to persist for a very long time. Not that it's being infectious, but the lesion, I mean. So it's going to be there even if there is a tissue treatment. So patient might get worried that the lesion refuses to go for some time. So it's important to educate them and let them know that, okay, it might persist for a very long time after successful treatment, but that does not mean that he's still about the infection. Thank you very much, Dr. Justice. Well done.
Wow,
Thank you so much.
so much. Thank you so much, Dr. All, Dr. Jamila, and the others contributed. Okay, let me just quickly take the comments on Dr. Justice for the presentation. I saying, well done, contact tracing is important. Okay, we've mentioned that. Which of the drug is used in treatment of contacts? Elema?
Yes, please. Dr. Ibiti has done well. Please just post I don't want us to miss that question we've been attempting to answer. We'll be sleeping for days. Please, somebody to post the paper. Let's attempt it quickly. If we finish on time, this particular presenter will take his on.
Okay.
Thank you.
Okay, so sorry, Dr. Tarabi, please unshare. So sorry. Okay, so can I go through the chat, or I will post it to the group? Can I quickly go through the chat, or I can skip that? Hello, ma.
Please go ahead and read the chat, please.
Okay, so Dr. Justice, a lot of thanks for the presentation. Okay, so Dr. Atta is saying the mites are more active during the night, and also patients' inactivity during the night heightens our senses of the pruritus. Okay, thank you so much. Thanks for the presentation. What is nodular scabies? Okay, then, okay, Dr. Justice, please just take notes. Maybe we just take all of them. Let me just go through them quickly. Maybe you can open the chat and look through with me. So Baranocin is not meant to protect the staff, as you mentioned, under treatment of crusted scabies. Rather, it protects the patients from any surrounding environmental organisms. It is reverse Baranocin that protects the staff. All right, thank you, Dr. Itohan. Dr. Abo says, thank you. Did you say tie the clothes in a bag for how long? Okay, please just take notes. Dr. Hart says, thank you. Dr. Jamila, thank you. Okay, so Dr. Paul says, thanks for the great presentation. Melatonin topical lotion can also be used. So what type of hypersensitivity reaction is scabies? Okay, he has mentioned the type 4. Is it a sexually transmitted disease or a transmissible disease? Dr. Justice, please take note of this. So Dr. Ede is saying topical or systemic use of corticosteroids may mask the clinical picture of scabies and lead to another uncommon presentation of scabies incognito, okay, which can easily be mistaken for other skin disease. Okay, yeah, that's why he said you have to treat the scabies completely before you use steroids. If you use before, it can cause scabies incognito. And the others, thanks from Dr. Wiki. Dr. Olaleke says, thanks for the excellent presentation. Is it right to state that the diagnosis is nodular scabies, considering the location of the lesions in the genital area? Okay, so that's the second question about nodular scabies. Thank you, Dr. Jamila. Please, is there room to repeat the causes of ivermectin you mentioned for classic and crusted scabies? Okay, I think she's already mentioned that. She mentioned you have to do on day 1 and 8 for classic, and then 1, 2, and I think up to 4 doses for crusted. If yes, is there a maximum number of repeats? Okay, she has mentioned that. Okay. Dr. Itoma says, in answering the question on health issues to be addressed and how to educate the patient, you mentioned the health issues, but didn't quite educate the patient. How would you educate the patient on the health issues associated with scabies? Okay, Dr. Justice, please go ahead. Hello,
Sorry,
Dr. Justice.
I kept getting calls. Sorry about that. Yes. Good morning. Thank you so much for the questions. I don't think it's a sexually transmitted disease. I'm not very conversant with the term transmissible. I would like to go with that, but please, I'd like to check that up so I don't give wrong information. Then I chose to go with the definite variants, which were classical or crusted. I didn't want to focus on the fact that it was just in genital area. Although, yes, that was the picture that they gave to us. But since we're not having the typical crusted pattern, I chose to go. Sorry, please, I'm still having repeated calls. I keep ending this. So I just go with the classical scabies. Thank you. I think most of the other ones were already addressed during the. Then yes, to address the complaint, yes, one of our chiefs already talked about it. I also should have added the fact that that the health condition can actually be intense and the itching can persist afterwards. And I also should counsel the patients strictly on not just the treatment, but also the health preventive protocols, washing the clothes and ironing them, washing the beddings, then making sure that we have access to all their contacts and treating them as well. And then their beddings or if we're not able to wash and iron, to tie them in the tightly sealed pack and keep under sun for about 2 to 3 days. I'm supposed to actually say all that and counsel the person extensively in that regard. I didn't go too deep into that because I needed to also meet up with time. Thank you very much, Chief.
All right, thank you so much. I think we've addressed this. Okay,
Chief.
Okay, so
correct something. Scabies is considered an STI because of close proximity.
Okay. Thank you, Chief.
All right. Okay. Dr. Bimpe, please can you help us share the question paper, October 2020? Just help us share the question. Christopher, I don't know if we'll take comments from our teachers before we move on. I don't know if we have time.
We can take comments, but I must appreciate the speaker. He did well. At the time, I was almost confused if it was the dermatologist. He did well, and I love the way he answered. He kept to time. I was a little distracted, but I love the way he answered the questions. And I must appreciate the dermatologist. I love the way specialists come in when their topics are being discussed now. Dr. Jamila, thank you so much. Dr. Itoha, I don't know if you're the one that asked question or you may comment. Then Dr. Awa, thank you. Dr. Ifoma too. I noted these names. Thank you so much. So Dr. Awa and Dr. Jamila, I think those that spoke practically said everything that needs to be said, and the speaker did justice to the topic too. So from my end, I must appreciate all of them. Thank you so much. I don't know if all that but was there any speaker? I don't know if you have any question you want to ask, anything that was asked that wasn't so clear. Dr. Justice.
Thank you very much, Chief. Yes, thank you very much, Chief. I appreciate the comments. I think most of the issues I had were brought up in the questions and I jotted a lot of them down. Thank you very much. The only other challenge I had earlier was whether saying classical scabies is appropriate or I should just say scabies. I don't want to go and dig a hole for myself in case I meet a scenario like this. Okay,
please, in exam, just say scabies, please. Just say scabies. It's like most times they bring just pictures. Do you understand? Yes, only way you can say crusted scabies is when you see, maybe they show you an or a genital that looks so thick. Once it's really, really thick, that means that they want, if you say scabies, to give you the answer. But if you say crusted, they'll give you the full mark. So if you see that it's so
thick, really thick. The skin is, you see plenty lesions. You see a lot of lesions on the skin, really thick. That will tell you that you're dealing with crusted. They just give them crusted. Any other thing, please just say scabies. If it's not crusted, you can't even visualize the lesion. Like I know there was a particular year, some of the participants, they used the history because the picture was not so clear. They were never appreciating the lesions. So like that, you can just say scabies and you're fine. I would say play safe in exam. Don't try to go. How do you know from the picture that this is nodular scabies? But you know, those are asking you that for your time is over and you don't answer anything. So scabies, but if they show you very thickened skin, that means they want you to say crusted scabies. I hope that's clear.
Yes, thank you very much.
Nodular and classic are the same thing. I mean, the nodular scabies and classic.
They're different. Okay. Nodular is different. Nodular, you see nodules. You see nodules. So show you nodules on the lesion, on the skin. Most time, you see nodular scabies on the genitals. Most time. So they want you to talk about nodular scabies. They will maybe show you a genital. But if you do not see something that is, but because of how funny it is, might not, because most of them bring pictures, and some of these pictures are not so clear. So once you say scabies, at least you've gotten something. Then say nodular scabies, meanwhile it's classic scabies. Do you understand? But once the skin is thick, you can see it now. So it's easier to say crusted scabies. So that's why I just said generally, if you come across any scabies question and the lesions are not so clear cut, the skin is not thick, you cannot appreciate the lesions, because crusted scabies, even the blind will see it. Even the blind, that's how obvious it is. So if it's not so obvious, the skin is not so thick, you don't see this yellowish crust, something yellowish on the skin, then most likely it's not crusted, it's just normal, classical, or any of the other scabies. Scabies classification, they have a lot of classification, not just, so we won't go into all of that side, we won't confuse you guys. So as I explained, if it's not, the skin is not thick, you see yellowish lesions and all, yellowish plaques and crawls and all of that, more on the hands or any part of the body really, and it don't give you history suggestive of immunosuppression, most likely it is normal scabies, any of the other scabies. The ones that tell you immunosuppression, renal organ transplantation, HIV, history suggestive of immunosuppression, then you now see the skin is thickened, you see yellowish cross and really thick, like unified plaques. Sometimes they even show you some, you might even see the lesions, the burrows are so obvious and all. Then you might want to go for processed scabies. I hope I've not confused you.
No, ma, thank you so much.
You're welcome.
Okay, so we're going to take question 4 now. And Dr. Kalamama has volunteered to attempt the question. I don't know if that's okay.
By me, it's fine by me. Anybody, if Dr. Kalamama will choose to answer the question, we encourage her. Those that are active, those that want to pass, we encourage them. Really.
Okay.
Dr. Kalamama, thank you.
Okay.
Who's going for exams, be ready to support her. She'll be the key speaker. Then others going for the exam should bring in. I know I'm echoing. Thank you.
All right. Okay, thank you so much, Chief Christabel. Thank you so much, class rep. Thank you so much for giving me the opportunity. Okay, so I'm going to read the question. All right, so a 63-year-old man was referred to you on account of progressive renal insufficiency over the past 3 months, associated with occasional dependent edema. He is a known hypertensive for about 20 years with fairly well-controlled blood pressure. Over the past 3 months, he has been suffering from malaise and back pain, for which he has taken various analgesics. He recently had a febrile illness for which he was treated with antibiotics and anti-malaria medications. Investigations revealed elevated creatinine of 255 micromole per liter, sodium of 146 millimole per liter, potassium of 1 millimole per liter, metabolic acidosis of 22 millimole per liter, hypercalcemia of 2.8 millimole per liter, phosphates, reduced phosphates of about 2.2 millimole per liter, And as well, uric acid 6.6 millimole per liter with anemia of 7.5 gram per liter. Then WBC was reduced to about 5.3 times 10 raised to power 9. There was also thrombocytopenia of 68 times 10 raised to power 12. Urinalysis revealed proteinuria of 4 pluses, hematuria of 1 plus, and then a granular cast. The question A says, mention 5 possible causes of renal insufficiency in this patient. My number 1 is hypertension, because this patient has been hypertensive for 20 years. My second option would be multiple myeloma. Why? Because this patient, the age is seen in patients 60 years and above, and then commoner in males as compared to females. The patient also has a history of the CRAB, has hypercalcemia, has renal insufficiency, there's anemia, and then there's also bone pain. So that's my backing for multiple myeloma. Then also, I also thought of an NSAID-induced nephropathy. This patient has been on an analgesic, of which I'm thinking is an NSAID that causes vasoconstriction of both the afferent and efferent arterioles. Then also sepsis. Sepsis could also be a cause for this patient. Sepsis could cause pre-renal AKI for this patient. Although the patient seems as if he has a background CKD, since he has had a past history of renal insufficiency for 3 months, like an acute on a chronic thing, which sepsis precipitated it. Then I'm also thinking of an AKI secondary to severe malaria, because this patient was treated for a febrile illness of which we are unknown of, and then he got some anti-malaria medications. Then also I'm thinking of a nephrolithiasis, because the calcium level is high. So I'm thinking of maybe calcium stones that must have predisposed this patient to nephrolithiasis, leading to AKI on a background, maybe probably CKD. And then lastly, I'm thinking of renal amyloidosis. So these are my possible causes of renal insufficiency in this patient. I don't know if we have add-ons as regards that particular question. I move to the next one. Okay, so for my most likely diagnosis, is multiple myeloma. For the reasons I previously gave, the age, his favor of the age is in favor of his sex. He also has the CRAB sign. So that's why I went with multiple myeloma. Then the next question says, list additional investigations and expected findings you would carry out to confirm the diagnosis. Okay, so to confirm the diagnosis, I want to do a bone marrow biopsy, of which it will reveal greater than or equals to 10% of the bone marrow plasma cells. Then also, I would want to do, since we're thinking of a renal impairment component with the multiple myeloma, I want to do a renal biopsy that may reveal the different types of the multiple myeloma, that the renal involvement, which will reveal maybe a cast nephropathy, which may reveal an AL amyloidosis, or which may reveal the mesangial proliferative glomerulonephritis pattern in this patient when we do a renal biopsy. Then the next question says, list additional investigations and expected findings you would carry out to confirm the diagnosis for this patient. So aside the bone marrow biopsy that could be done, we can also do the serum protein electrophoresis, of which it will demonstrate the M protein, which is the monoclonal protein. You will notice we see the band spike there in the monoclonal protein, and then it's greater than 3 grams, I think 3 grams per liter or per day. And then the ESR will be elevated in this patient. The ESR will be elevated in this patient. And then another investigation we can do is urinary serum free light chains. And then we are said to see an abnormal free light ratio in this patient. Then if we do a peripheral blood film for this patient, we see the Rollo formation in this patient. And then we'll notice thrombocytopenia, which this patient was thrombocytopenic. And then also leukopenia. The patient was also leukopenic because the WBC was reduced. And then we can also see pictures depicting leukoerythroblastic picture. We'll see premature white blood cells, and then also red blood cells when you look at it on the blood film. Then urinary, we're going to, another beneficial thing is 24-hour urinary protein. We notice that patient had proteinuria of 4 plus, of which nephrotic is 3 plus and above. Then patients also may benefit from urinary albumin creatinine ratio of which it will be deranged. Then a serum lactate hydrogenase can be done, and then it will be elevated in this patient. So other investigations we can do MRI of the spine to rule out bony involvement, of which it will reveal the osteolytic lesion or fractures or osteoporosis in this patient. We can as well go as well as doing beta 2 macroglobulin. That is actually prognostic. If elevated, it actually shows this patient has a poor prognosis, so that helps to prognosticate this patient. Then also, if the serum albumin is reduced, that shows some level of severity. This patient has lost so much of protein, so that means it will reveal reduced albumin level in the blood. So that shows severity in this patient. So the next question goes: what 3 renal lesions could be associated with this condition? So we can actually have a cast nephropathy, of which I think the patient has granular cast. A cast nephropathy can be an association with the condition. Patient can also have an amyloid light chain and amyloidosis, nephrolithiasis, Fanconi syndrome that's got to do with involvement of the tubules, as well as the monoclonal immunoglobulin deposition disease. These are things that can be associated with this patient. So the next question is, how would you manage this patient? So for using the principles of management, we know that it is actually multidisciplinary, of which would involve the hematologist, the nephrologist, the orthopedic surgeon because of the bone pain, oncologist because the patient will benefit from getting chemotherapy, the pharmacist. This is actually a high intensive case. That patient may need an ICU case depending on the severity, and then also a blood bank and scientist, because if the patient is thrombocytopenic, patient may need platelet concentrates. If the patient has low WBC, you just treat according to how the blood picture presents. So basically, for the principle of management, I'll give health education on this patient, counsel education on this condition, and then I will now identify and then treat the risk factor for this patient. This patient had a background urinary tract infection. I'll treat the infection because that could be a precipitant for this patient, and then also to halt the progression of the disease, I will monitor fluid input output and then avoid nephrotoxic drugs. Like the patient was on an antibiotic. We know that the macrolides are not so good with the kidney, so if he's on macrolides or he's on maybe gentamicin, I'll take him off those drugs and other nephrotoxic drugs, and also the NSAID that is also nephrotoxic. I'll take him off that. Then going back to the treating the disease proper, this patient will benefit from chemotherapy, and the chemotherapy that will be beneficial are chemotherapies that will not further impair the renal impairment of this patient, will worsen the renal impairment of this patient. The patient will benefit from cyclophosphamide, will benefit from bortezomib, and as well as dexamethasone. So these drugs are actually good for patients who already have a renal compromise. For other medications that the patient can benefit from without a renal compromise is the lenalidomide or melphalan. Those are things that can actually be given when there's no renal impairment, in addition to coexisting with the multiple myeloma. If this doesn't survive, this patient will benefit from a stem cell transplantation. So to prevent complications, this patient will benefit from the pneumococcal vaccine because there's a variant where we said they are at risk of post-streptococcal glomerulonephritis. So this patient will benefit from getting a vaccine to prevent such infection, and then a DVT prophylaxis. Then to treat the complications, we realized that this patient was actually anemic, so this patient will benefit from getting either a packed cell, and then we noticed that the platelet level was reduced. Patient may benefit from getting platelet concentrate as well, and then depending on what exactly we want, if the patient is not hemodynamically unstable, we can actually give the patient iron sucrose, and then give erythropoietin to bring up the HB to about 12 grams per DL for this patient. Then now correct the hypercalcemia by giving phosphate binders, bisphosphonates, and then the patient may also benefit from liberal hydration to prevent stones, which I was thinking the patient may be predisposed to stones, already has stones. And also the patient may benefit from loop diuretics because using the side effects, they actually reduce calcium levels. So we can actually give loop diuretics in treating the hyperglycemic state. Then also to correct hyperuricemia, these patients will also benefit from xanthine and oxidase inhibitor, of which febuxostat is best for this patient as compared to allopurinol because of the renal impairment. Then for hyperviscosity syndrome, or AKI, this patient may also benefit from plasma expander. If all of these do not suffice, then this patient would need hemodialysis and then possibly renal transplants in the end if there's further worsening of the renal status. Thank you so much.
Wow, thank you so much for that beautiful presentation. Let's keep the thanks coming, and let's take comments and questions from the. I don't know if we have comments from the participants who need to add.
Is Dr. Kalama my nephrologist?
Cardio-nephrologist.
Ha! See the stuff.
She's a cardiologist.
Wow.
So much. Okay, let me see. Okay, there are some hands up. There's some hands up. Okay. Okay, so we'll start with Dr. Amakri.
Okay, good morning, my teachers and colleagues. Okay, thank you, Dr. Florence, for your beautiful presentation. Just an add-on. For the other associations for the kidney disease, for the multiple myeloma, you mentioned the AL amyloid. There's also the light chain deposition disease. We have the interstitial fibrosis and tubular atrophy. Then AKI, that is, they can have AKI. They can also have, for this patient, ATN from sepsis. Then for the most likely diagnosis, initially it was called cast nephropathy, which is the most common. But now I think the name has changed to light chain cast nephropathy. Then your investigations were good. But for our management, your principle of management, first of all, the patient should be properly hydrated with large volumes of fluid, about greater than 5 liters of fluid. At the initial part, we're not doing input-output, strict input-output, but we're hydrating this patient because they usually come dehydrated. So we're using crystalloid, enteral intravenous crystalloids. They also want to manage sepsis in these patients. Yes, you talked about management of the urinary tract infection. Then for the hydration also helps with the reduction in the calcium level. But if after hydration our calcium level is still, it helps with reduction in calcium level and also sodium bicarbonate. If the calcium level is still elevated, that's when you go ahead to correct with the intravenous bisphosphonate. Then also you will stop the NSAIDs that patient has been on for the pain. Then for anemia, you talk about correction. Yes, then for a specific patient can have a plasma exchange. Then for the furosemide, you say furosemide is actually good for them, but furosemide also promotes cast formation. So the use of furosemide in this patient should be avoided, also considering the fact that they come into dehydrated, so they will not be progressed to acute kidney injury. Then for our specific management, myeloma is usually incurable, but we use high doses of corticosteroids, preferably dexamethasone, 20 milligrams orally BD for about 4 days. Then other drugs that can be used, we can use our bortezomib, which you mentioned, which is a proteasomal inhibitor. Then also thalidomide has been found to be useful, and also plus or minus our doxorubicin. Other drugs that can be used are the alkylating agents, such as the melphalan and cyclosporin, which you mentioned. Thank you.
Well, thank you so much, Dr. Amakri, for that beautiful addition. Okay, let me just add a little to the investigation: serum-free like protein, then 24-hour urinary protein, and electrophoresis. Then for the medications, I saw this called Cybord. That's for cyclophosphamide, bortezomib, and then dexamethasone. Okay, so we still have more hands. Dr. Mamadou, you have the floor. Then after that, Dr. Anthony. Hello, Dr. Mamadou.
Thank you so much. Good morning, our teachers and colleagues. Sorry, Dr. Flores, thank you for the beautiful presentation. I just wanted a clarification on what you mentioned in terms of the NSAID. You said both afferent and efferent constriction of the arteries. Because what we know, we typically do ACE efferent, then NSAIDs AA afferent. So I don't know, the NSAIDs do both, constrict both, That's where my problem is. I just wanted clarification on that. Thank you.
Maybe we can check. I think the last time I checked, I think I
you
saw
want
both. I think we had an argument.
Okay, thank you. I think Dr. Mahmoud is correct. I took note of that
Okay.
too. Sorry.
afferent, yes.
All right. All right.
Okay,
Thank
Dr.
you.
Mahmoud is correct.
Thank you.
Thank you so much,
Thank
Dr.
you.
Mahmoud, for that. I think I noticed that too. Okay, Dr. Anthony, please go ahead.
Okay. Good morning, facilitators. Good morning, everybody, and thank you, Dr. Becky, for doing justice to the question. Initially, I was thinking that you were in nephrology, but that also means that you had probably done a lot of justice to this question. But a lot of the other speakers have said what some of the things I wanted to say, but I just wanted to add one or two things. One is that when we're talking about diagnosis, she said something about when you have greater than 10%, donor cells greater than 10%, because there's no doubt this particular patient not just had what we call the myeloma defining event, all of them were there. If you're talking about the biopsy, when you say greater than 10%, you can have if you have clonal plasma cells greater than 10% with myeloma defining event, or you can have clonal bone marrow cells greater than 60% without myeloma defining event. You must take that. Let's try to bring that into cognition. Two, that the other thing she mentioned, which a lot have said, okay, the other little things I also wanted to add, for instance, if patient is going to be on intravenous, if you want to give bisphosphonates, correct the hyperkalemia, remember that if the EGFR of this patient is less than 30 mL per minute, per 1.37 minutes, so it may not be, it might be good to avoid it. She had also talked about transdialysis, which was good. In some cases, they will say, in cases where you have, for instance, they already will know that this patient has a renal impairment, you may need to use what to call, you may need to dialyze the patient, yes, very fine. But if you begin to progress and things, if you may want to do a transplant, but remember too that this patient is at risk of a transplant. That's another thing I wanted to mention. Well, yeah. Well, it's okay. I think by and large, I want to thank her. She did a very wonderful job. Just that little one or two things I wanted to add. But I also wanted to ask a question. They said the most likely diagnosis. Maybe somebody can help us clarify. For me, I would want to say that the most likely diagnosis is multiple myeloma. But when the last speaker or the one before said the diagnosis would be cast nephropathy, maybe if somebody can help us tease that out, that would be nice. Because for me, I would say that the most likely diagnosis in the context of this patient is multiple myeloma. Thank you.
Well, thank you so much, Dr. Anthony. Okay, maybe after Dr. Lawrence, maybe our teachers will help us clarify on that. Okay, so Dr. Lawrence.
Thank you, Dr. Ekele. Good morning, my facilitators and my colleagues. Dr. Florence has done justice to the topic, but I just want to add one or two things. With the degree of proteinuria that this patient has, he has 4 plus of protein in the urine based on the question that they gave us. In addition to the management she has highlighted, it would have been better too if you had anti-proteinuric agent into this patient, probably ACE inhibitor or ARB, if the BP can tolerate, to reduce the degree of proteinuria, because proteinuria on its own is injurious to the tubules. That's number one. And number two, we know that multiple myeloma can affect kidneys in many ways. It can cause perirenal AKI because of persistent vomiting, because of hypercalcemia, causes vomiting, cause polyuria, so dehydration, perirenal AKI. They are equally prone to infection because they are losing immunoglobulin in the urine. So they are prone to infection too, which can cause either perirenal AKI or even acute tubular necrosis also. So the use of furosemide, just as Dr. Binabo said, it might not be appropriate in this patient because most times they are always dehydrated. So, and because of the degree of proteinuria, most likely there is a nephrotic syndrome component, which might be like MPGN in this patient. So the patient will benefit greatly from having anti-proteinuric agent if the BP can tolerate it. Thank you very much.
All right. Thank you so much for those additions. I was wondering whether ACI and ARV, whether they are not part of the nephrotoxic drugs we should avoid. Okay, our teachers will comment on that. Okay, so let me just quickly go to the chat so that we can, our time is quite fast spent. So thank you so much, Ma. Do we still go ahead and mention, that's from Dr. Jamila, AKI among our differentials? Thought the disease has been there for 3 months. Okay, so she's asking if we should use CKD instead. Dr. Yahya Mohammed says it's a beautiful presentation. Apart from spinal MRI, skeletal survey using X-rays helpful. Then Dr. Owal is saying, thank you. In this patient, will 5 liters of fluid not overload him, given the background renal impairments? And then management of MM also depends on age, less than 75 years, greater than 75 years. Thank you. And others are saying, thank you, thank you. Thank you so much for the excellent presentation. Dr. Owal, I say, wow, thank you, Dr. Briggs. Dr. Muhammad says, thank you so much. All right. Okay, so Ma. Hello, Ma.
Hello, Chief and
Christabel.
Chief and
Hello?
any comments are yes.
No, can you hear me? I'm thinking that some hands are still up.
I think it's old hands. They've not spoken.
Okay.
Yes, Ma, they're old hands.
Okay, that's
Please,
fine.
can you lower your hands?
Right. So, but Dr. Binabos, okay, everybody has lowered their hands. All right. So, thank you. That was a very beautiful presentation. Okay. So, Dr. Binabos, still want to talk?
No, sir. No.
All right. Okay. So, most people have said everything. I think the issue of the diagnosis, I'll go with Dr. Agbo, because what the patient has is beyond just the kidney disease. Okay. So, it's multiple myeloma. Okay, so I think multiple myeloma is a better diagnosis, unless now I want to add with renal complications, but multiple myeloma covers everything. It's okay to just go with multiple myeloma, okay, as diagnosis. That's my opinion, but maybe Dr. Shitsu might have a different opinion. Sometimes, anyway, let me not say some things I'm not supposed to say here. But I was feeling that we forgot something. I thought I saw something like potassium of 1 or something, 1 point something in the question. Please, could you check again?
It's 4.1.
So it's 4.1. 4.1.
Oh, I thought I heard 1 point something. Okay, I was thinking that we completely forgot that, both in the management and even as an etiology. Okay, so when the speakers, everybody did beautifully. I thought Dr. Kalamama was a nephrologist when she was talking. So I really have nothing much to add. Thank you.
Please, you want to comment on the fluid? Someone was wondering about.
What? Go ahead. What's the question?
So the question was, Dr. Mercury said you should give up to 5 liters. She was asking, in view of the renal impairment, so wouldn't that overload the patient?
No, I said.
Sorry. Go ahead. Go ahead.
For cast nephropathy, you need to hydrate the patient properly, at least up to 5 liters of, as in, you need large volume of fluid for hydration. Not in this patient's already elderly, maybe the fluid management will be patient specific.
Exactly. Okay, so that's the answer to it. You know, you need to be, she was just talking specifically about the particular condition. Okay, so but when you want to, fluid management is usually individualized. Okay, so when whatever condition, so you have to look at everything, input, output, the condition of the patient, the heart, everything. So it's usually individualized. Okay, so that's the answer to that question. Thank you.
Thank you, sir.
Thank you, sir. Chief Chitus, any comment?
Well, I think everything is in order. The diagnosis is multiple myeloma. The mechanism of can either be cast nephropathy, it could be myeloma, kidneys, okay, or even be a perirenal issue as well. So, but for this particular question, the diagnosis of what was asked, and they gave us things that were beyond just the kidney. So it's better to say multiple myeloma. Even if it was just the kidney, it's safer to say multiple myeloma, right? To be sure that there's nothing else amiss somewhere. But for a general medicine question, I think multiple myeloma is the best thing to say.
Thank you, sir. Thank you. Dr. Opute.
Good morning, everyone. Sorry, Dr. Shitu, I just wanted to ask a question. In the context of this patient having like proteinuria, the nephrotic range, and knowing quite well that the renal presentation of the plasma cell dyscrasias can either be AKI, where you have the cast nephropathy, dehydration, hypercalcemia, sepsis, or drug-induced. And in the context of a CKD, where you also can think of cast nephropathy, AL amyloid, and the monoclonal immunoglobulin deposition disease. And also in the context of proteinuria or nephrotic syndrome, where we'll be tending more into the AL amyloid and also the MIDD. And for
so
tubular dysfunction,
you can't think of myeloma kidneys.
Yes. So in the context of this proteinuria, let's assume other aspect, let's say they're pointing it more towards a renal, more into the renal pathology. Would it be right to say, since this patient has with proteinuria or nephrotic range, I would say, because this is 4+, to actually go for AL amyloid or MIDD?
Okay. Well, I agree with you on that point of view, but the matter is it's a general medicine question, so it won't go that deep. And if we can put off the recording. Okay, Dr. Christabel.